Question is, which of the following is a common pathology associated with ureteric injury while performing surgical procedure of abdominal hysterectomy? Pelvic endometriosis, adenomyosis, hydrosalpinx, and ovarian teratoma. So the question is asking for which one of the following pathology, if we perform a surgical procedure of abdominal hysterectomy, will it lead to injury to ureter? So the answer will be pelvic endometriosis. So whenever we are operating for pelvic endometriosis, there is higher chances that ureter injury can take place. Why? First is the concept of water under the bridge. Water under the bridge. So what is the concept of water under the bridge? So water means ureter. So urine containing ureter means water. Bridge means uterine artery, the artery supplying the uterus. So we can see in the diagram that there is uterus. Supplying the uterus is uterine artery, which is coming from the internal iliac artery. And then there is a ureter in the brown, which is going toward the urinary bladder, So we can see that there is a ureter, which I am highlighting. There is ureter, highlighting in yellow, which is passing to the urinary bladder. So at this point, below the uterine artery, the artery that is supplying the uterus, there is ureter below. So when we are performing hysterectomy for the pelvic endometriosis, there is high chances that we can injure the uterus. So that's why. Second thing is, in pelvic endometriosis, there is dense fibrosis. Second, there is distorted pelvic anatomy. And third, there is adhesions, which involve ureter, uterus, and ovaries. So performing abdominal hysterectomy in the pelvic endometriosis will most likely lead to ureteric injury. Now, seeing why other options are wrong. So our correct answer is A, pelvic endometriosis. Why other options are wrong? In the adenomyosis means endometrium in myome, or endometrial glands or endometrium in myometrium. So during the time of the menstruation, there will be pain. So in the adenomyosis, the uterus is generally enlarged and boggy uterus, and it does not distort ureteric anatomy. So ureteric anatomy will not be disturbed. So B is wrong. Hydrosalpinx, it's a tubal pathology. So it is the problem of the fallopian tube. So it's a tubal pathology, and it is not associated with ureteric injury. Then again, ovarian teratoma, it is usually localized. So it's a localized ovarian tumor, and it's not a classical cause of ureteric injury during hysterectomy. So most common risk factor for ureteric injury in gynecological surgery is when there is distorted pelvic anatomy. So whenever there will be distorted pelvic anatomy and you are going to do hysterectomy, you are going to injure the ureter. And the distorted pelvic anatomy is especially found in the pelvic endometriosis. So which of the following are correct regarding pathology of stress urinary incontinence? So what is the pathology? First is hypermobility of the urethra. So this is correct. Even this is the most common mechanism. So what happens? That there is loss of pelvic floor support. There's loss of pelvic floor support, leading to bladder, neck, and urethra becomes mobile. So they become mobile, which leads to urine leaks during coughing and laughing. So whenever the abdominal pressure increases, the urine is going to leak. So first is correct. Coming to second option, ascent of bladder neck and proximal urethra above the pelvis. It's not the case, it's opposite. So there is descent. So bladder neck descends, and so urethra loses support. So the support that urethra was getting because of the pelvic floor, it lost. We can understand it. So in the normal pelvic anatomy, you can see there is ureter, uterus, then there is vagina, there is rectum here. So posteriorly there is rectum, then there is ureter and vagina, and then in the front there is bladder. There is pubic bone, and there are normal urethral support. So to urethra there are normal urethral support. But whenever the pelvic muscles get weakens, there is loss of urethral support. So loss of urethral support leads to descent. So the bladder descended and urethra comes down. And so the urethra that was getting support from the pelvic floor muscles get lost. In this schematic diagram, you can see that during the normal times, normal pelvic support, there is bladder and there is the urethra. But whenever bladder descends, so in the time of the stress incontinence, bladder actually descends. The question was the same. So the bladder descends and urethra goes down, and urethra loses the support. So it loses urethral support. So coming to our question again, that there is ascent of bladder neck and proximal urethra above pelvic diaphragm. No, it is descent of bladder neck and proximal urethra below pelvic diaphragm. So second is wrong. Now third is there is lower urethral pressure. Yes, this is correct. So because there is now deficiency of internal sphincter, there can be low urethral closing pressure and there will be sphincter stress incontinence. Now fourth is increased detrusor activity. No, detrusor activity increased is mechanism of action in the urge incontinence. Or overactive bladder. So this is another cause for incontinence, which is different from the stress urinary incontinence. So fourth is wrong. So first is correct and third is correct. So first is correct and third. So B is the correct option. Now coming to next question. 58. Which of the following operative procedure is or are conformity for the diagnosis of bicornuate uterus? So we have two types of uterus. One is the bicornuate uterus, second is the separate uterus. Now actually there are many types of uterus, but separate uterus and bicornuate uterus are the one which we have to differentiate. So in the separate uterus, there is failure of resorption of Mullerian septum. So the septum is present, but the fundal contour is intact. While in the case of bicornuate uterus, there is failure of fusion of the two Mullerian ducts. So there are two Mullerian ducts which have to fuse together, but they did not fuse. And so there is failure of complete fusion of Mullerian ducts, which leads to the fundal contour is not intact. So there is deep fundal indentation about more than 1 centimeter. So there is heart-shaped contour. When in the case of the separate uterus, the fundal contour is normal and convex. So we have to differentiate. So we have to make the diagnosis of bicornuate uterus. So in the case of, so A option is the dilatation and curettage. No, dilatation and curettage is not going to diagnose uterine malformation. Only doing hysteroscopy, no. Whenever we will be doing only hysteroscopy, it will just show the cavity. And not external contour. So we will not be able to see the contour, that if it is normal or there is deep fundal indentation of the bicornuate one. So we are not going to see this. See, is hysteroscopy and laparoscopy? Yes, this is correct, because hysteroscopy is going to show you the internal anatomy. So there will be, you are going to see internal cavity. So through hysteroscopy you are going to see internal cavity, while through laparoscopy you are going to see the external uterine fundal contour. So this is your gold standard. This is your traditional gold standard. Now hysterectomy is not a diagnostic procedure. You are going to remove the uterus. No. Why are you going to remove the uterus? just for diagnosis of the bicornuate uterus? No, there's no meaning of it. So answer will be C, hysteroscopic and laparoscopy. So the question was about the operative procedure, because now there are many other things which have come for the diagnosis of bicornuate uterus, that you are not going to do these operative procedure. You are just going to order either MRI, modern MRI are going to tell you the contour, and you are going to tell if it is bicornuate uterus or not, or recently 3D ultrasonography have also come, so you can find out through this. But the question was about the operative procedure, so the